Good morning, Kansas City. This is Steve Stites, Chief Medical Officer here at the University of Kansas Health System. I am joined this morning by Dana Hawkinson. You know what I like to call him, Dr. Hawkeye,
right.
Dr. Hawk, our Medical Director of Infection Control. And we have a special guest today, Mario Castro. Mario is the Division Director for Pulmonary and Critical Care Medicine. He is also the head of our clinical translational science and research efforts here at KU in our collaboration with multiple other institutions locally, including UMKC, St. Luke's, the Osteopathic Medical School, and really across other areas around the state. So it's a really important position for us. And Mario has been intricately involved in research studies looking at COVID-19, and we're going to ask him to comment on some of the things that he knows about. But first, I'm going to turn to Dr. Hawkinson. Dana, what are the numbers like this morning? How are things looking? Big weekend.
Yeah, hi. You know, luckily our numbers are still good for what that's worth. They are about the same as they were last week. We have 31 in-house, but we currently have almost half of those in the ICU, so that's actually not good, especially if it's taking a trend toward the more critically ill patients.
And Mario, you've been part here for a while, but you also came from St. Louis at Washington University.
Correct.
I know you've been in contact with some of your colleagues there.
Yes, I've been in touch with my colleagues there, and you know, unfortunately, the social distancing just did not work on that side of the state. And St. Louis has a congregation of individuals that were not distancing themselves, and I think that resulted in a lot more cases ended up in the hospital. And in the ICUs there, they have over 50 patients on the ventilators, which is about 4 to 5 times what we've been having here.
Yeah.
So it really makes a difference if you can stay at home, and stay away from groups, and that allows us not to spread this virus.
It really does work. And again, hats off to the Core 4, Wyandotte, Johnson, Jackson County, and Kansas City, Missouri. Kind of got ahead of this curve, and I think it's really affecting the curve in our area. We've been seeing relatively flat numbers here, which is great, which is not what St. Louis has been experiencing, I know.
Right.
Talk to us a little bit about some of the research studies that you have and that you're helping work with here at KU around COVID-19.
Sure. Well, I think it's an exciting time because we as clinicians taking care of COVID really are struggling to know what exactly should we use for treatment.
Right.
We know supportive care, helping people with breathing, oxygen, those things get people through this crisis and through this infection. But we've been using a lot of other medications with our ID colleagues and so on that we're really just in the experimental stage, I would say. And it's not the way we like to practice medicine. We like to know what's the evidence behind it. So I almost argue that every patient we should be treating should be in a study, because we should be learning from every patient and what they can teach us. And so I just wanted to hit 3 studies this morning briefly and really just share with you all kind of what we're trying to advance in terms of the knowledge. But there are over 40 studies that are being contemplated here at KU Medical Center, and it's an exciting time, I think, as we think about different approaches. How can we treat this viral infection?
Mm-hmm. So talk to us a little bit about the HERO study. I know that's going to be of really big interest to folks since it involves healthcare providers.
Yeah. Well, HERO, as appropriately named, is trying to save our healthcare workers. It's trying to come up with a strategy perhaps that will help us in terms of our healthcare workers that are being exposed to COVID. So we're proposing a study that's going to be rolled out across the entire United States, 60 different sites. We're aiming to enroll 15,000 healthcare workers. And by healthcare workers, we don't mean about you, Dr. Stites.
Yeah,
we mean
people are really doing the work. Is that what you're saying, Mario?
Right.
Thanks a lot for that, brother.
We mean about the the nurses, the medical technicians, the people that are cleaning these rooms. Those are the people that are really being exposed and sacrificing, and heroes in a sense, to really be out there in the front line for us. And we know that protective gear works. We know that protective equipment works, but we don't know if medication would help us protect us. So the HERO study is going to take a medication called hydroxychloroquine or Plaquenil. And this hydroxychloroquine is the medication that's been talked about a lot in the press. It's been used for a number of years for malaria prevention. And so what we're doing is using it to prevent COVID. And so healthcare workers that would qualify for the HERO study would log on to a registry, and the registry is HEROES, HEROES, research.org. And heroesresearch.org, you just log on. Anybody can do that. That's a healthcare worker. And from that registry, we are going to take people that qualify, that are exposed to COVID, bring them here, and then enter them into the study. And they'll get 30 days worth of treatment, either hydroxychloroquine or placebo. So you get a flip of the coin, 50% chance of whether or not you're going to get the real thing. But we need to know, is this medication safe first for healthcare workers? Because there are side effects with every medication we've been throwing at our patients. And we need to also know, is it effective? Can it prevent COVID infections in our healthcare workers? And it's a striking reality, Steve, if you look at our colleagues in New York, in Seattle, 20-30% of healthcare workers were infected with COVID. So 1 out of 5, 1 out of 4 chance is not very good for a healthcare worker.
Yeah, you bet. So this would be a chance then to try and prevent that transmission by taking hydroxychloroquine and seeing if it improves the outcome for healthcare workers. And I think as we hear talk about reopening, Dana, that will be especially important because we don't have a vaccine yet. We don't have treatment. It just means that there's going to be a level of SARS-CoV-2 with us for a while.
Yeah, absolutely. And that also goes to the point of, well, healthcare workers are getting infected at the same rates of community people as well. So this may also, if they're continuing to take it on a once daily basis or whatever the regimen is, would that help prevent community spread? And again, keep our healthcare workers safe and healthy so they can come in and treat the patients.
So with that introduction, I'd love to open up to questions that any folks out there might have.
This is Cher from Fox 4. Good morning. Hope everyone had a great weekend. Quick question. I just saw a Johns Hopkins study that says coronavirus can now spread on shoes up to 13 feet, and that it can live on that surface for, I think it said, up to 3 days if not cleaned. Speaking of healthcare workers and all the gears that you're taking, I'm assuming that they're changing shoes and their booties, I'm guessing, that they wear over their shoes and mopping floors. Have you seen that study or have a reaction to it?
Dana, I'll turn to you.
Yeah, last night, I don't know if this was the Johns Hopkins study. Certainly I saw a study out of China that was indicating that they were also looking at the virus on surfaces. Again, they were detecting, most of these studies that they are detecting the virus on surfaces, things of that nature. For the most part, again, it's RNA detection. It's the genome detection. So it's not really clear if it's actually infectious particles, but rather maybe debris from the virus itself. And I would have to look at that study in general, but we know that it can be detected on different surfaces for up to 3-7 days. This is probably similar. I'd have to look at that, but the question is, even though we're detecting it, and certainly if it's I guess expelled from the body during cough or sneeze in any short amount of time within an hour or two, you could still probably absolutely detect it. It may be infectious at that point, but a lot of these studies are just detecting the RNA, and they don't really make inferences of it's infective. And so we'd have to look at that. But we know that it can be detected on different surfaces for some amount of time.
Yeah, I think the key is there's virus particles that can be detected. Those are not infectious to people. You have to have the virus, and the virus has to be culturable in order to know that it's growing and therefore can be infective to someone else. And I don't know about that either. We can look at that to get back to you. I'm not sure I've seen that. Have you seen that? I'll have to go back and find the Hopkins study, but I bet it's the Wuhan data. So we'll get back with you about that.
Okay. Thank you.
Hey, Dr. Sykes. This is Mike Cherry from KCPT.
Good morning.
I understand that there's been almost an unprecedented level of communication and discussion among chief medical officers during this. Can you talk about how often you talk to your colleagues at various hospitals and what the topics are and how this bodes maybe for future cooperation?
Yeah, that's a great question. Man, that's like a softball right there. I appreciate that.
I know, sorry.
No, I don't apologize. I'm happy about it. No, you know what? Hospitals are by their nature competitive. We're all out there trying to get business that, take care of folks, but also be successful, and chief medical officers are like that. But at a time of a pandemic, it's a lot more important to work together than it is to work apart. And so we've had calls 3 times a week just to touch base about how things are going at each of the institution, help answer questions that each other might have, share our experiences, and really work together around things like, OR schedules and clinic schedules and personal protective equipment and the rules around infection control, and then trying to come together to help ourselves all understand where everybody is, make sure we're giving the right messages to our CEOs and to the emergency medical crews that are out there. And the goal is that we're all going to have to take care of COVID-19 patients, and we want to do the best job possible. I think anytime you forge a relationship with people, then those relationships can help sustain you across the enterprise and across the future. So I do think it's going to help us in the long run. I think there's been an unprecedented degree of cooperation between KU and multiple health systems, including St. Luke's and Liberty and North Kansas City, Shawnee Mission, and Olathe and Lawrence Memorial and others as we shared information. And so that's been, there aren't a lot of wins for the world in this infection and what it's done to our community and to our economy and to our health. But if there is a win, it's in people coming together to accomplish a greater good. And that's what you hope you can hold on to as you go into a period of recovery. And remember that even as we go from, this policy of, shelter at home and things like that, eventually the day after tomorrow comes and you have to resume some part of normal life. COVID-19 as a disease is going to have to be with us for a long time until we have a vaccine or meaningful therapy for it. Because that is a true statement, and it is a very true statement, then what we have to do is work together to help monitor how the community's doing as you begin to reopen it. And I don't know how that's going to be all handled politically, but I know from the standpoint of our chief medical officers across our area, I think it's really important that we stay in touch to know what's going on in our hospitals so we get early signs of any kind of rise as we talk about reopening. The other thing I would just say is we've also worked together in educating our region, Western Missouri and Kansas, because we've been in conversations with chief medical officers throughout our bi-state area. I think that's been a big win. So
yeah, we've been in touch with ICU critical care directors in the region, which has been a first for us.
And I should point out, Mario's helped lead that, and what that meant is he early identified, hey, gosh, we have to think about ventilators as a resource as well. So let's start planning for that, because we know that's what ran out in New York and Italy and other places.
Exactly. So one of the first steps we took is, when you plan in public health, you need to assess what's the potential here. And so every critical care director we met, and by Zoom, as we all meet nowadays, and we assessed how many ventilators do we currently have, ICU beds, and then how many could we have at each hospital, with the idea of any one of us are being overwhelmed, we could reach to our neighbors, even across the health system, and say, hey, I don't want to resort to drastic measures of triage. I want to send this patient over to be cared a place that has that capacity.
Right, and we can either transfer patients, or we could transfer ventilators too, because
exactly.
some rules have gotten a little easier around that for us. So, other questions?
Yeah, hi, my name is Celia with Kansas News Service. I have a couple questions about testing. So where are you guys? I know you guys have in-house testing now. How are your criteria compared to the state lab's criteria in terms of, can you test more people who maybe aren't sick enough to be hospitalized?
Yeah, so, the testing criteria tends to move every day, and that's not a criticism, it's a statement. And it's that way because differing equipment may be working one day, not working as well on another day. So we are able to test quite a few folks here, and we have some additional testing, and we've got 2 different types of equipment that are doing it. And so our criteria has really been any inpatient, people who are undergoing certain kinds of procedures which may generate an aerosol, and it may, like a sinus surgery could have the virus go airborne, so we would want to know about that. as well as our healthcare employees and select patient populations. We've not opened it up more broadly. There are some places that have opened it up more broadly because they think they have the testing capacity, but even that varies from day to day based upon really how well that equipment's performing on any given day. The other thing is that we feel like it's really important to do all the folks who are called patients or people under investigation, or what we call rule outs for short. And the reason we do that is if you're in the hospital as a rule out, you're using up all sorts of PPE, personal protective equipment. And so we think that's the most important thing to, if we don't have to do that, let's stop it. And I would say, based on our CMO calls, everybody's approach is the same. We're going to make sure that we got all the patients we need to tested. We've got all our employees tested so they can be on the front line taking care of folks. And then we have special disease populations, and then we might be able to broaden that a little bit. The state of Kansas and KDHE and the health departments are all getting more equipment in. We are all trying to get more equipment in because we recognize that from a public health perspective, if we're going to start opening up society, one of the most important things you can do is have broad and easily accessible testing so that you can help manage how many patients with COVID-19 are out in the community. I don't know if either of y'all have anything to add to that.
Yeah, absolutely. Our testing is still looking for, again, evidence of the virus. It's a nucleic acid test. We still haven't gotten into the serology or the antibodies. We've talked about that last week. Eventually, as Dr. Stites talked about, we would like to so that we understand the full prevalence of the disease out in the community at this time, and also looking back to see if other people were exposed and maybe just not as ill.
Yeah, so there will be, I think this area is going to change dramatically over the next, oh gosh, I want to be an optimist and say 2 weeks, but really by the 1st of June, I think we'll have a lot broader testing capability across our region. I think most hospitals have developed their own in-house test or have gotten their own in-house test. And the other important piece is you have to have the swabs and the serology, or not the serology, the viral medium, in order to be able to run those and the reagents. And so all of that has to be in place from a supply chain perspective to really open up our testing capability as high as all of us want to do. Because make no mistake, we all want to accelerate the amount of testing available.
And then I wonder if I could follow up. So I wonder what you guys are hearing about how things should work for people who are uninsured. There are two pieces to this. Of course, one of the stimulus bills includes the idea that testing should be free for people who are uninsured, and that money should eventually flow through Medicaid. So I wonder, have you guys received the logistical information you need at this point to not bill uninsured people and instead bill Medicaid for that? And then the Trump administration has also said that they want to spend part of the CARES Act on treatment for uninsured people, but it seems there are a lot of unanswered questions. What information do you have at this point?
Yeah, that's a great question, and we have a lot of unanswered questions as well. There's a lot open to some interpretation, but we did get some of our first amounts in as a result of the CARES Act and other acts that are out there. I'll have to let you know specifically about whether or not we are getting reimbursed for the treatment of people without insurance under those. I don't know the answer to that question right now. I will say to you that we will test anybody. That's not right. If you're someone who needs a test here, but based on the criteria we set out earlier, we'll test anybody, and we have been doing that. I think the point that no one should have to pay for a test and everybody needs to get tested can get tested, that is true. We all want and aspire to that. We need greater testing capability to match that statement. Right now, because we still have limited testing capability, really for the most part across the region, we really have to stratify. But one of the things we don't stratify is your ability to pay in relationship to a test for SARS-CoV-2.
Say, Mario, this is Mike with KCC again.
Hi, Mike.
Do you have a sense as to? I got knocked off the call earlier, so I didn't hear exactly what your role is. But do you have a sense that there's enough ICU beds available throughout the region?
Yeah, we've been planning this for about 4 weeks now, where every one of the critical care directors in the regional hospitals have been getting together. And we looked at how many ICU beds we currently have, how many ventilators we currently have, and then if push comes to shove, if we have a lot of COVID patients going into the ICU, what is our surge capacity? And we're quite impressed, I mean, that we can actually use ventilators that are in the OR, other locations that we typically don't use, with critical care supervision adequately to treat patients. And so we hope, that we're not in a situation that our colleagues in other regions of the country, and that we have that capacity. But we're close to over 1,000 ICU beds in the region available to accommodate our patients if need be.
And I think, we keep looking at all the different models, and it depends on which day of the week and which model you want to look at. We either have plenty of beds or we have nowhere near enough beds. and the only way we're going to know that is by walking the path together and figuring it out as we get through that, I think. Other questions?
Yeah, it does seem to be fairly wild. There's a lot of sort of gloom and doom out there. Even the Missouri Association has put out some stuff that updated the Harvard stuff. So it's, based on what you're seeing now, as we reach the peak, how do you all feel about the availability of ventilators and ICU beds and things like that?
Here in Kansas City or across our region?
In the Kansas City.
Yeah, Mario, I'll answer. Do you have a sense of that? And
I think we have the capacity currently with what we're dealing with, and our hope is that we've blunted the curve and we'll have this low level of capacity, ICU ventilators that we will have readily available. Right now we're, knock on wood somewhere, we're very
I usually use my head for that because that works pretty well. But I have COVID dreams, and I wake up almost every night thinking, oh my gosh, what do we not do? What do we not think of? How did that happen? And they're not pleasant dreams. But the data, I think, Dana, suggests that we may have helped blunt the curve a little bit by the very early shelter in place from the core four. That was really good. I don't know how to say it any other way, and I think that's been helpful. Now, without widespread testing, we don't really know the incidence in the community. What we know is the number of hospital admissions we have and the number of ventilators we have. And so that's an imperfect measure. But as a measure, we're not seeing a huge rapid rise. But that's not to say it won't come. We are if you look at the different data sets, it can suggest we are going to peak somewhere in about 2 weeks, 10 to 14 days, all the way up until the 1st of June. So we have a lot of time to try and find out where we're going to land, and the more data we have, the better off we are. But we're still, unfortunately, I think I described this once before as a baseball game, and I said we're still in the first inning. We're out of the first inning. We're still behind. The score, we're still behind, but we're not way behind like some areas of the country are, or regions of the world. But I would say we're still in the second inning, maybe getting into the third. But we got a long ways to go. A lot of baseball to play, Dana.
Yeah, I was again out at the park this weekend and was able to smell the blooms. So I'm pretty sure, hopefully, I don't have COVID. Yeah, I can still smell. But I think it's overall looking good. The real concern is that I did see a lot of young people congregating together. So I think it's imperative on the parents or the guardians to really try and tell them, please stay away apart from each other, because it only takes one or two from another household to bring it home to mom and dad, to grandma, to grandpa. I do think Governor Kelly and Secretary Dr. Norman were ahead of the curve nationally. I think Mayor Lucas was ahead of the curve, especially in Missouri, to try and do the shelter in place, stay at home, and hopefully blunt that curve, but we still have a lot of work to do.
Yeah, it's really good, I think, fortuitous for us, political leadership, and you look at the difference between Kansas City and St. Louis, and just to say that's the opposite of the influenza epidemic of 1918, and when Kansas City did not shelter in place and had a higher mortality rate than St. Louis. So, other questions?
Well, this
Hi,
is,
this is Melissa with Channel 41. Speaking of the models that you just referenced, looking ahead several months, June and on, it's not showing deaths here in the metro, but is that because the data just doesn't exist that far in advance? And I'm talking about the Washington University model.
Yeah, you mean University of Washington model, I think.
Correct, sorry.
Yeah, so those guys, they're very smart. They said that predicting a situation like a pandemic that has never happened before in a modern age, it's been over a century, and trying to figure out what the respirable, meaning when you breathe in and out pathogen, what it's going to mean is a lot like doing a long-range weather forecast. And, those aren't the most reliable. No, not trying to impugn our weather forecasters, but it's just hard. And so I think that's why the University of Washington model tends to end a few weeks out, and you're trying to figure out what it means. And partly because we don't know the extent of community spread. And so the University of Washington model uses deaths in order to calculate that curve. Think about this, right? So you don't really start manifesting symptoms after you've been infected with SARS-CoV-2 for anywhere from 2 to 10 days afterwards. It takes 7 to 10 days after that to get sick, and a few more days to end up in the ICU on a ventilator. So you're looking at a 10 or 14-day lag before you're even on the ventilator. And then most patients who are on a ventilator before they die are on that ventilator for 10 or 11 days. So really, deaths lag anywhere from 2 to 3 weeks behind where you are in the community. So as a result, you have to be a little careful. Deaths are a very real denominator. They give you real good data, but it's a real long lag, and it's kind of depressing. So what the University of Washington is saying is we're not sure what that future looks like, because we're also not sure what other interventions are out there, and it's just hard to explore the model. We'll make longer projections the more information and the more data we have. Here's what we know, though. This is a respirable pathogen. Coronaviruses tend to be around most all year long, but in differing levels in the community. We think this one may well act like that. We don't really know. But if it's like all the other coronaviruses, that was what will happen, which means that we're going to have some level of coronavirus, SARS-CoV-2, post the peak. And because we didn't infect a lot of people in the population, because we did shelter in place, which saved lives, it may still have a lot of people who are susceptible. So it just means that for the foreseeable future, we're going to have to be really careful. And that as much as possible, you're going to have to stay 6 feet away, wash your hands for 20 seconds, cough into your elbow, don't go to work when you're sick, monitor your temperature, and as possible, shelter in place. We know that at some level, we're healthcare folks, right? At some level, there's an economic and a social cost that those who are guiding us politically are going to have to weigh. But our job is to help with the healthcare side of that, and that's what we'll continue to do. Long-winded answer to say that's because they don't really know the future there at University of Washington, nor do we.
Thank you.
Hey, Dr. Stites, this is Mike. There's a lot of talk about what's going to change, how COVID's going to change the world. I'm interested in your thoughts on what's not going to change in the medical system once this is over with. You've already talked a little bit about that. This is a competitive healthcare environment. I mean, I don't suppose you're all going to be joining hands and singing around the campfire for the rest of your lives. So what is not going to change?
Well, that's a great question. Okay, I'm going to take a stab at it. I think it's going to depend on how darn hot the campfire is. Because here's what I would say. At some point, we're all going to have to say we've got enough personal protective equipment and enough pharmacy supplies that we can reopen operating rooms and clinics. That's really why we closed them to begin with, along with the need to not introduce more risk to individuals who came in for those things. We'll have to have enough testing in order to test patients the day before the day of surgery. Because we do know that patients who have operations are at increased risk if they have COVID-19 and they don't fare particularly well. So you don't want to do a surgery on anybody, and because it's an asymptomatic state, you're going to have to test. I think at some point in the future, we're going to have to open those things back up because there are patients who are delaying surgeries. They're not emergency surgeries. let's say you need to have a hip replaced or a knee replaced, but those hurt. And the only effective therapy is to get that done. And so once we understand the disease and our supplies a little better and we can test well, and we know that somebody can go back home to a safe environment and do physical therapy, perhaps on Zoom, or whatever the recovery thing may be, then I think we're going to have to start accelerating our ability to care for folks. The good news is that because telemedicine has taken off so remarkably, which is a great outcome of this. Mario was talking about being excited. He didn't be excited, I'm joyful, but be excited because we have a problem to solve, and that's our job.
Yep.
I think telemedicine has excited us because it's been our job to take care of people, and we've been able to do that with telemedicine. I think that combination of things, testing, supplies, telemedicine, will allow hospitals and health systems to open back up to take care of patients. I think we're going to be living in a changed world until there's a vaccine and drug therapy available that we know is effective. Hopefully it'll be things like hydroxychloroquine or I can't say it this morning. It's Monday morning. Tocilizumab. Thank you. I need an assist. Things like that will help change remdesivir, things that will help change the outcome of this disease. And I think once we do that and we understand it better, then we'll do a better job in offering more effective therapy, and we can even be, more direct. I think hospitals have to be more competitive, but I think around COVID-19, we will always be cooperative because it takes a combined effort. I hope it means we're going to be able to work together a little bit more. One thing y'all need to remember is that health systems across the country have taken a huge financial hit as a result of this because we've stopped those things that make the most money. And, that's just altruism, right? There's no, we wouldn't have wanted to stop operating rooms. We didn't want to stop the clinics, but we had to do it. And it was absolutely the right thing to do. And everybody in Kansas City came together and did it. So we all did the right thing. Whether you're a for-profit, not-for-profit, it didn't matter. We all did the right thing. I think around COVID-19, we will all work together to continue to do the right thing. Because if one or two hospitals close in Kansas City, we don't have the capacity to take care of all those folks. We are not an overbedded community as we once were. So we really have to work together to make sure that we can all survive, and that'll lift all boats. Which reminds me, I want to turn to Mario. There was an article that came out, news that came out this weekend about lots of small clots being part of this disease, the importance of anticoagulation. Any comments on that early and often, maybe?
Sure. I mean, I think it's one of those things we're learning as we go. And the observations that physicians have made taking care of these patients is that they have a high propensity of blood clots, both blood clots in the legs, but also the very small blood clots in the lungs. And so now most of our patients in the ICU, we're anticoagulating. We're putting on blood thinners. And so we think that this virus does damage to the inside lining of the blood vessels, the epithelium. And because of the damage, it causes these microthrombi to form. This has not really been seen. I don't know, Dana, if you can comment on that in other viral infections like this.
No, certainly, we have listservs that infectious disease and other physicians can go on, and they notice that fairly early. I would agree. We have heard of anosmia or olfactory neuroinvasion, which can maybe cause a lack of smell for other viral entities, especially upper respiratory viral entities. But certainly the propensity to cause the blood clots in this seems to be fairly unique at this point.
Clots can be everywhere. They can affect heart, they can affect liver, they can affect kidneys, right? I mean, these patients have a high incidence of kidney failure, too.
No, it's something that we've been concerned about on the ventilator capacity, but it's also the potential of dialysis is a limiting factor, and so we've been really trying to work hard and increasing our capacity for that as well.
Other questions? I have time for one more question here.
This is from the health system. I have a question from Facebook.
Okay.
We have just asked twice. Have you seen results treating patients with hydroxychloroquine and azithromycin?
Yeah, I'll turn to you two, the experts.
All right, why don't you go first?
Sure.
I'll follow up.
I think, like a lot of things, when you're not in the midst of things and you haven't really studied it well, we don't know the true answer. At this point, azithromycin has fallen out of favor, but hydroxychloroquine is still our mainstay for treatment. I would say that some of us have seen small improvements, not dramatic improvements.
Yeah.
Yeah, and I would like to say, certainly Dr. Castro was talking about azithromycin. There are a lot of caveats and problems with these studies that originally came out. One of those was a study out of with a French researcher. The journal that the study was published in actually took back their support for that journal article, and then that way azithromycin dropped off because of that. The other thing is the Infectious Disease Society of America, IDSA, which is our main infectious disease physician body here in the United States, recently published treatment guidelines. And it should be noted that in all of the treatment guidelines and recommendations, it does say may consider use in a clinical trial format. And all of that evidence is weak evidence that they made that recommendation on. And so that just goes to show you there is still a large knowledge gap, and we are trying to figure that out by doing all of these trials. And we are working on it tirelessly, day in, day out, to try and find the best treatment, the best timing of treatment. And so, however, there still is that large knowledge gap there.
So as we close today, final thoughts from either of you?
Well, I just want to emphasize the HERO study. I'd like all healthcare workers, in the region to participate in the registry. It's heroesresearch.org, and heroes with an E, and that's going to be exciting because 15,000 healthcare workers across the U.S. who are going to enroll into the study and hopefully come up with some important information.
Yeah, that's a really big deal. I think we have to emphasize how important that is. Dana?
Yeah. Again, it's still going to be cool out, but it will be nicer, and temperatures are going to continue to warm. Please go outside, but again, please stay apart, stay away from other people who are not in your household, because all it takes is one person to bring it to the household. Continue to wash your hands, don't touch your face, social distance, physical distance.
So, I'm just kind of an Ozarks guy. I love going down to the Ozarks and paddling around in a canoe. And listen to that, obviously. Sometimes in the morning it's a little misty. You can't quite see anything. You get on the river and you're like, I wonder what's around that river bend. Not quite sure what's around that river bend. And that's kind of where we've been. We've not really known what's around the river bend here with COVID-19. But what I think we can see is that maybe, just maybe, the sun's kind of breaking through just a little bit, and maybe it's beginning to get in a little more focus. But in order to get there, in order to do that, we still have to stay safe. So don't let up. BKC, this region has done a remarkable job of sheltering in place, staying at home, staying 6 feet apart, washing your hands, cough into your elbow, don't touch your face. And we know that because our data says that. So let's figure out what's around that river bend, but let's do it by staying safe. We'll get there together. And the good news is there hopefully is a lot of river left to paddle. So thank you all for listening. We'll be back tomorrow. All right. Thanks, guys.